Hi everyone, I want to talk about leukemia. Leukemia. Before going into the details of leukemia or lymphoblastic lymphoma, let me give you examples of childhood cancers. We have leukemia, lymphoma, rhabdomyosarcoma, Wilms tumor, neuroblastoma, retinoblastoma, brain tumors, and spinal cords. If you check my channel, I made presentation on leukemia, lymphoma, rhabdomyosarcoma, Wilms tumor, neuroblastoma, and retinoblastoma. Brain tumor and spinal cord tumors will be produced later. Acute lymphoblastic leukemia and lymphoblastic lymphoma are now characterized as one entity. Why that? Because they are very similar. They are both malignant disease of the bone marrow, and it is essentially that early lymphoid precursors proliferate and replace the normal hematopoietic cells of the bone marrow. The commonest childhood malignancy is acute lymphoblastic leukemia, and it's about 25% of all cancers in children. The peak incidence is between ages 2 to 5, and the incidence is increasing in recent years. The B cells are more affected than the T cells. The B cells will be affected at about 80% of the times, compared to 15% when it comes to T cells. Natural killer cells are also affected, but at a lower rate of less than 1%. ALL and LBL is worldwide. It is higher in Hispanics, more than in whites, whites more than in blacks, blacks more than in Asian, in that descending order. What are the possible risk factors here? The increased age of the father could be a reason, and increased birth weight of the child, and of course, genetics. Genetics because monozygotic twins will have higher likelihood. It's also found in Down syndrome and neurofibromatosis or ataxia telangiectasia, and with or without environmental factors. The clinical features are hepatomegaly, that is, the liver will become enlarged. Also, the spleen will be enlarged. There will be anemia, and that will manifest like pallor. There's possibility of fever when there is infection. An infection could affect the oropharyngeal region, the lungs, and perineal region. There's possibility of bleeding, particularly when there is thrombocytopenia, which will manifest with ecchymosis and bruising. And when lymph nodes are checked, there will be lymphadenopathy. Like I said, with thrombocytopenia, there's possibility of ecchymosis and bruising, but there will be petechiae and purpura. The affected child will become fatigued, and the white blood cells will be down, giving leukopenia, and could be high, giving leukocytosis. The joint and body pains will be present, and the child may even be limping. The child may not be able to bear weight, and the bones will be tender. When the CNS is involved, it's going to give features similar to that of meningitis, like headache, vomiting, lethargy, nodular rigidity, that is neck rigidity, central nervous system symptoms, or cranial nerve pulses, and is likely going to give painless testicular enlargement. The C-cell type can occur at mediastinal region. And when that happens, because that is where the thymus gland is, and that can compress the superior vena cava. And when there's superior vena cava compression, there's going to be severe vena cava syndrome. And that will include chest pain, swallowing difficulty, breathing difficulty, that is dyspnea. The neck veins will be distended, and there's possibility of respiratory distress. So sometimes when a child has been complaining of pain in the bones and you find these features, it's likely you are dealing with T-cells type at mediastinal region. The investigations you are going to do will be many, but we're going to start with complete blood count. And when complete blood count is done, that's going to be increased white blood cells greater than 10 times 10 raised to power 9 per liter. And hematocrit will drop. Differential count will reveal decreased neutrophils and decreased platelets, because I've mentioned earlier that there will be thrombocytopenia. When you do peripheral smear, you're going to find more blasts. Then the bone marrow aspirate cytology will reveal lymphoblast. When the lymph node is excised, you can do the excision with biopsy or fine needle aspiration cytology. The cell morphology could be small, uniform blast with decreased cytoplasm or hidden nuclei. The periodic acid shift test will give Schwanke and periodic acid shift positive test. There's likely going to be weak non-specific esterase with negative myeloperoxidase. The tumor lysis syndrome here will lead to increased uric acid, increased potassium, increased phosphate, and that will lead to decreased calcium, and there is possibility of increased lactose dehydrogenase. There's a separate audio presentation, PowerPoint presentation on tumor lysis syndrome that I've already published. So I'm not going to waste your time going into details of that here. If you check that, it will be more self-explanatory. I'm going to check for PT and APTT with fibrinogen D-dimer to rule out what is happening with disseminated intravascular coagulopathy. Cytogenetics will reveal whether there is Philadelphia chromosome or not. When Philadelphia chromosome is picked, that is a bad prognosis. You're going to have chest X-ray or CT of the chest done, particularly in case of T cells involvement, either T cells, ALL, or LBL, and the mass in the region. Immunophenotyping will be welcome here. Part of the investigation is also lumbar puncture before systemic chemotherapy, and why that? That is to assess for paraneoplastic bodies and CNS involvement. There's a separate PowerPoint presentation that I've published on paraneoplastic syndrome. So kindly check that out. That will give you details. You need to ensure adequate platelets and make sure that the PT and APTT is within normal range before you carry out the investigation, the lumbar puncture. How to make specific diagnosis here? What we'll do is peripheral smear showing moderate amount of cytoplasm with multiple nuclei. Look for RROs that will be absent and eosinophilic granules will be present. Flow cytometry to exclude myelin lineage, and specifically as far as lymphoblasts are concerned, there will be B lymphoblasts with B cell markers, and the B cell markers are CD19, cytoplasmic CD79A, and cytoplasmic CD22. Must be negative for CD3 and myeloperoxidase. Okay, that is for the B lymphoblast. The lymphoblast must be negative for CD3 and MPO, but be positive for B cell markers. T lymphocyte, on the other hand, will be positive for CD3, but be negative for B cell antigens, that is, must be negative for B cell markers, and MPO, that is myeloperoxidase. I think that is clear. So let me repeat for the purpose of clarity. How will you know that you are dealing with B cell lymphoblast or T cell lymphoblast? For the B lymphoblast, there must be B cell markers present, CD19, cytoplasmic CD79A, and cytoplasmic CD22, and must be negative for CD3, must be negative for myeloperoxidase. Then you are dealing with B lymphoblast. The T lymphoblast, on the other hand, must be positive for CD3, okay, but be negative for B cell markers and be negative for myeloperoxidase. The treatment will be in the next video. Thanks for listening. Please kindly subscribe so that you can get these immediately they're published. Thank you.